Our next talk titled Trauma and Healing in Muslim Communities, a Multidisciplinary Lens. It will be led by Dr. Rahaf Alasiri and Ms. Heba Ragheb, and I will be the moderator for that session. My name is Samah Al-Hawashki, and I'm a psychiatrist currently completing my child and adolescent psychiatry subspecialty training at the University of Toronto. And I'm also on the organizing committee for the Canadian Muslim Mental Health Conference this year. So welcome. We are really excited to have you here. We had great presentations this morning, and I'm really excited for this upcoming one. So just a couple of housekeeping things before we start our talk. There will be interactive polls in some sessions, so look out for those and participate. The more you participate in things like the polls or posting questions or posting things online, such as on Instagram, Facebook, or Twitter, by using our hashtag CMMHC2020, the more points you would earn and the more likely you would be able to win either a complimentary registration for the 5th Canadian Muslim Mental Health Conference next year or one of two $25 gift cards from Amazon. Remember that today's sessions are accredited, including the research poster session that we just had. And in order to obtain the accreditation hours, please complete the Google form survey that will be sent to you after the conference. Resources can also be found at the muslimmentalhealth.ca website. So I will be introducing our speakers. So I will start with Dr. Rahaf Al-Asiri, who is a good friend and colleague. She is a psychiatrist that specializes in perinatal mental health and child and adolescent psychiatry. She is a staff psychiatrist in King Abdulaziz Medical City Hospital in Jeddah, Saudi Arabia. And she is also a lecturer at the Department of Psychiatry at King Saud University, Jeddah, Saudi Arabia. She completed her medical degree at King Abdulaziz University before finishing the psychiatry residency training at the University of Toronto. She obtained a fellowship training in both child and adolescent psychiatry and women's mental health, with a focus on parenting through trauma, migration, and complex and chronic mental health conditions. Dr. Alasiri has worked with newcomers and refugee families and in the Child's Aid Society in Toronto. She is currently affiliated with various orphan homes to provide mental health services to children and youth in the government's care. So welcome, Dr. Rahaf. Next, we are presenting, I'm presenting Ms. Heba Ragheb, who I'm also excited to hear and listen to her talk. She is a senior psychotherapist and a clinical social worker. Currently, she is the founder and owner of Hayat Wellness Counseling, providing trauma-focused and faith-based interventions to individuals and families. Ms. Ragheb has completed her Honors Bachelor's of Science in Neuroscience and Psychology and a Master of Social Work at the University of Toronto. For over 10 years, she has worked in hospital and community mental health settings throughout the GTA. Ms. Ragheb has worked abroad to establish the first pediatric social work model and clinical social work license framework in Dubai in the United Arab Emirates. She is a published research investigator with a deep interest in trauma, psychosis, integrated psychotherapies, and faith-based interventions. She has been an advocate for mental health, collaborating with community organizations to support refugees, newcomers, and marginalized communities. Ms. Ragheb is continuously working to support new pathways of collective healing in diverse Canadian communities. So with no further delay, I welcome Dr. Rahaf Al-Asiri and Ms. Heba Ragheb.
Thank you so much, Sama, for this very nice introduction. And it's been really nice working with all of you as a team, both organizing the committee as well as on this topic, which is a topic that is one of my passions, as well as Rahaf's as well. So let me start by sharing my screen with you so you can see our presentation. So Rahaf, why don't you just greet our attendees while I do that.
Assalamu alaikum. Thank you everyone for the kind words, and thank you Samah for the introduction. And as Heba said, this is a very near and dear topic to both of our hearts. And I guess we're going to start our presentation with an invitation to everybody who's in the audience to first practice compassion and curiosity for whatever rises during our presentation. I think that whenever we talk about trauma, a lot of our own personal experiences may bubble up and come to the surface. So it's important to take care of ourselves and slow things down and take a breather and honor these areas of discomfort and continue to look at them as areas of ongoing growth and areas for developing resilience. So the second invitation is that for everyone who's hearing us right now to maybe bring a notepad and a pen, or maybe write it down on your electronics. Just write down your own reflections or questions or anything that may come up for you for future exploration. I think the presentation we're sharing today might be the beginning for some of us, might be midway for others, and might be another opportunity to look at things from another perspective for the rest of us. So we really need to normalize and understand that trauma is quite complex and it's overwhelming at some point. And also we need to understand and remember that we're resilient and we're strong as a human race. And we've been doing this for centuries and centuries, and we'll continue to grow stronger and learn from our experiences. So I welcome everyone, and we'll start with the case.
Rahaf, I just want to interrupt you for a second. Some people are saying they can't see Heba's screen. So Heba, can you log off and back on, and or like, yeah, unshare and share? Thank you.
Sure, let's try this again. Oh,
There we go. Alhamdulillah.
give me thumbs up, Sama. Good.
All giving you thumbs up.
Perfect. So I couple just what Rahaf is saying, exactly everything that was she was saying about the invitation, with an additional thing to not be judgmental today with yourself. If you find that we're talking about things and you're like, oh, you know, I find myself that I may have done this in the past, or I may have done something that would have been perceived as not the ideal thing to do with someone who've been traumatized, especially that I know that we are including a lot of healthcare and frontline workers today in our attendees, not to be judgmental about that, and to know that you're in the right place. This is a safe place for learning. We are addressing those areas, and we all have our blind spots, and we're here to learn, and so we can improve ourselves through reflection and through the growth that we're doing today. So on your notepad, or if you even want to share in the comments section, when you hear what comes to mind when you hear the word trauma? The comment section here. maybe that's too much multitasking. I'm being ambitious. I track, but if you're seeing the comments and if you want to tell us what they're saying, that would be really appreciated.
Adversity.
Adversity.
Pain.
Pain, yeah. One more.
Trauma, remembering about bad events.
Yes, recalling bad events.
Actually have one more, flashbacks.
Flashbacks. So everybody's right on track with what they're thinking. We're gonna explore and dive deep more into study. We want to tell you the case study in the very beginning, and then we're going to go through trauma and what is trauma. And then we're going to ask you in the very end, after we've done all our learning, what you may think about it. So we have a 35-year-old woman who is physically healthy, who is referred by a family doctor to a psychiatrist with a sudden onset of severe anxiety in the postpartum period with thoughts of suicide. She reports fear of harming her child. She has recently immigrated to Canada and her husband is working abroad. She discovered that her husband has another wife and discloses marital problems. She has hypervigilance, and has reoccurring nightmares, and appears to dissociate in the office. Keep that in mind until we get to the end of our presentation. I want you to consider what is trauma. Trauma is a single or multiple series of events that are traumatic. They can completely overwhelm a person and their ability to cope because of how overwhelming the experience is. They have a really profound negative impact on a person's mind, body, heart, soul, and spirit. There are several types, and we can say that it's really most severe when it affects a person in their critical developmental periods in a younger age. However, everybody can be affected by trauma. And I'm going to hand it over to Rahaf to tell us more about the types of trauma.
So, types of trauma. I would say that scientists and all of us in the community actually for years have tried to slice the cake in different ways. Everyone looks at it from their own perspective. Some can only see, if you're referring to the picture in front, the blue side. Some can see the red side, others see the yellow side, while the person who is experiencing the trauma actually sees it from the inside and all they see is darkness. So right now we're gonna look at how we've divided trauma in the literature in different ways. So one way was dividing it by duration, acute versus chronic. Another was by exposure, direct or primary trauma versus vicarious or secondary trauma, or by the description of the type of trauma, physical, sexual, verbal, emotional, medical, relational, spiritual, or financial. And then we can also divide it based on who gets affected in the trauma. If it's the individual or a group of people, the collective or historical, or intergenerational. So we're gonna give a brief about each one of those, or at least the definition, so that we can understand what we're referring to when we talk about these different types of trauma. And again, for the scope of this presentation, we're looking at trauma from a macro level, because each one of these types can be a workshop in its own, or multiple workshops actually. So for the acute type of trauma, it's a trauma that comes in the form of single event, has a beginning, has a distinct end, like a sudden death of a loved one, like a sudden job loss, a car accident, or something that happens without prolonged exposure. It's clear when it's happened and when it ended. While the chronic one is the prolonged exposure to the traumatic event, something like the adverse childhood events, like child abuse that lasts for a long period during childhood, which is 18 years, or neglect, or witnessing domestic violence, or being in a violent relationship. Then we classify traumatic events by the exposure. It's either the person themselves experiencing the trauma firsthand, uh, or they can be experiencing the trauma secondary or vicariously through exposure to the trauma experience of others, which as a term like was discussed in 1995, and from there forth was discussed more and more. And here we're talking about trauma of frontline workers, police officers, healthcare providers in times of a pandemic, like right now, when we're watching others experience trauma in various forms, and that can be traumatic for us secondarily. And then, based on the description, which is pretty much self-explanatory, but I just like to highlight that there are types of trauma or traumatic events that we may not think of when we're talking about trauma, like workplace trauma, relational trauma with our superiors or our bosses, relational trauma with a friend, financial trauma, or medical trauma, people who experience bad outcomes in a hospital and do not want to go back to the hospital. And then, depending on who gets affected, if the individual, it affects a single person. Collective, it affects a group of people, like historically the genocides, the ethnic cleansing, slavery, that affects African communities in various countries in the world, or intergenerational. Now, intergenerational, in a brief, is the effect of trauma that can be transmitted from one generation to the next. But we're going to take a moment to maybe talk a bit more deeply about intergenerational trauma. The term was coined in 1996, discussed in the 2000s. It includes the concept of biological embedding or epigenetic regulation. The embedding is the process by which the environment shapes our human biology and our response. And epigenetic regulation, which has been the buzz for a while now in medical research, it's the process in which the gene expression vary through modification of the DNA associated proteins, not in the sequence itself. And that happens based on the environmental signals that we get. And I would say like these studies about the intergenerational trauma started when in the 80s maybe, or maybe the 60s even, when researchers noticed that children and grandchildren of the Holocaust survivors were overrepresented by about 300% in referrals to psychiatric care. At that point, that was something to observe and be curious about, and later study. Now, we've come a long haul since the initial curiosity and observation, and I would say that we are now getting new studies about how trauma is transmitted intergenerationally almost every week. And if you keep up with the research, you'll find more and more information and more different creatures being studied. You'll find that there are studies about the rhesus monkeys or rodents. And mostly, I would say studying rats is helpful because we share about 90% of our DNA with rats, and they're easier to kind of induce second and third generation. It takes shorter duration to get them, while in human beings, it takes about 12 to 20 years to study a generation. So there have been multiple studies with rodents that show that the effect of trauma on the first generation is transmitted to the second generation. One of these studies is the study at Emory Medical School in Atlanta, where they induced male mice a traumatic response by exposing them to cherry blossom scent and then zapping them. And then these rats developed this fear response to cherry blossom scent. With the next generation, they noticed the same fear response occurring when they smelled the cherry blossom scents, and they noticed that their sense of smell was heightened. And they noticed that, interestingly, that the sperms of that second generation carried those changes with the third generation in the male rats. So we now know that the trauma transmits from first to second to third generation. And there is also a study in the JAMA Psychiatry that followed mothers who suffered trauma as children and found that their daughters were more likely to struggle with depression and bipolar disorder in humans. And there are many, many more studies that I can go into in details, but maybe I'll just talk about the rodent studies about the relational trauma. They noticed that disrupting the maternal care in rats is associated with higher level of traumatic response, higher cortisol, lower neurotrophins. And these pups had symptoms of attention deficit disorder, and they found similar replication in human studies of correlating trauma to attention and changes in the biology of the brain. Now, I'm sure that we'll come back to talking a bit more about intergenerational trauma as we go on with the presentation. But now I wanted to introduce another concept of trauma, the intersectionality. It's important for us to think about, especially in the context of this conference, in the context of our Muslim community, because we do have intersections of adversities in the patients that we see in our communities. Intersectionality is the social, personal, and often political context where we experience trauma. And we have to understand that trauma does not occur within personal or social context alone, but it's often multifaceted, multi-layered. There's the race, the class, the gender, the first language, the religion, the immigration status, the body size, and so on and so forth. And Kimberly Crenshaw in 1989 was the first person who coined this term of intersectionality as she discussed the experience of African American women with trauma. And I'm sure we've discussed that, or you've heard that more in detail in the talks yesterday. But I thought it's good to mention it as well again, because we can benefit from using this term within our communities.
All right, thank you so much for explaining the types of trauma, Rahaf. I wanted to also share with you the prevalence of trauma. And I'm hearing from some of our organizing committee members that there might be some problems with my audio. So if that's the case, do let me know, and I'll be sure to try and fix it. but for now, I'll tell you a bit more about the prevalence of trauma. Canadians report having experienced a traumatic event in their lifetime. One, injured or killed. In terms of post-traumatic stress disorder, globally, the prevalence ranges from anywhere between 1.3% to 37.4%. And that can really depend on where the location in the world and if it's a war zone or how safe that place may be. The prevalence of lifetime PTSD in Canada is 9.2%. It's also interesting to look at the prevalence of trauma in the Middle East because as Muslim countries, I'm still getting that
yes,
audio.
sorry.
Okay. So let's give this a try. So we're gonna see if headphones would make it better. Okay. Can you tell us if you can hear me better with the headset on? Can you hear me? You can't hear me.
No, we can hear you, but talk more and then we'll see.
We're really test trying this. Okay, so we're going to be talking in a few minutes after we figure out this audio. Is it better?
Way better.
Okay, perfect. Alhamdulillah, everything is fixed. Okay. So next I was going to tell everybody that we're going to talk about the prevalence of trauma in the Middle East because there's not a lot of research about Muslim communities in Canada and North America in terms of trauma prevalence. And there's a lot of assumption, even in my clinical practice, that there isn't experiences of trauma or a prevalence of abuse or sexual assault in countries and back home. However, the prevalence isn't there because the research isn't there, but the occurrence and the incidence is actually rather high. So I tried to pull as much of the research as I could. And the publication that I found that was interesting said this particular research study found from 22 is a very high impact of trauma in the Middle East, particularly countries like Palestine, Syria, Iraq, Libya have been impacted by mass violence, conflict and war. Also, countries like Egypt, Jordan, Sudan, and Yemen have had a mental health crisis. And that there's been a lot of stigma in being able to do research and collect information. This next slide shows what type of trauma is contributing to the mental health impact. So we see at the very top the psychological effects of war. Next up, which is something we don't talk about enough in Muslim community, is domestic violence. And then refugees, physical effects of war, torture, child abuse, sexual assault and rape, divorce and separation, serious traffic accidents, which can be traumatic, victims of crime, elder abuse. Again, we don't talk about it enough in Muslim communities. And then bereavement and grief, and then child soldiers. I'll let Rahaf tell us a little bit more about the outcomes of exposure to trauma.
Thank you, Heba. And thank you for being so flexible with this weird technology experience that we're all
yes
together.
We should also mention to everybody that you're actually currently in Saudi Arabia with an 8-hour difference in time zone. So bless you for doing this so late at night. We appreciate it.
Thank you so much. My children understand that this is for me, and they gave me permission, and they were generous with their time.
That's good.
So, outcome of exposure to trauma. We have to remember that as we go through life, all of us experience one form of trauma or another. Now, the relationship between developing symptoms that are debilitating or mental health concerns or the way of coping that affects our ability to survive, that varies. It varies basically depending on the person's susceptibility to developing these kinds of sequelae of exposure to trauma. That's one. Two, it also varies depending on the type of trauma, the duration of trauma, when the trauma occurred, um, if it's collective intersectional traumas together, uh, that of course adds more chances of developing the traumatic response that we view as problematic. Um, but we're gonna say that um, there's like the study here, like we found that just highlights that in the US there's 80%, in the world it's 70%. Well, we know it's way more than that. It's about 100% that we all get exposed to a potentially traumatic event in our lives.
Rahaf, I'm just going to interrupt again. And if you can speak a little bit louder, because we're getting comments, just a little bit louder. Yeah, thank you.
Okay, here we go. I'll speak louder. Thank you for letting us know, by the way. So, yes. Now, we were saying that the literature says that most what we expect of response to traumatic events is resolution. And when we look at the literature, we have to bear in mind that they're talking about symptoms of PTSD or developing chronic interruptive sequelae of trauma. In that context, the studies say that most of them will resolve, but they do not necessarily, in all studies, take into account what gets internalized from these experiences of trauma. Now, we know that from each situation or experience we go through in life, there's a learning that goes with it that we keep with us. And that's part of our adaptive response to continue living the life that God gave us. But the thing is, some of us might internalize or take away learning from these experiences of trauma that are harmful for them. For example, self-loathing and blame. We know that this is it's one of the not uncommon themes for children who experience trauma, that they self-blame. There's shame and guilt that can be internalized, or self-punishment, or self-bullying, negative internal kind of self-talk, poor self-esteem that can result from experiences of trauma, social isolation, or lack of hope and ambition, where a person takes away from the repeated experiences of trauma that there's no hope. I'm just gonna get through another traumatic event. Now, what we see or what gets flagged more in the communities is more of the externalized behaviors for both children and adults that they might take away from the traumatic experience that they need to be on the edge, defending themselves. So they have more verbal hostility, more aggression and assault, rule breaking, antisocial behavior. They might have self-harm behaviors or suicidal behaviors. And actually, now that I'm talking about suicidal behaviors, suicide is a tricky one because it can be part of the internalized behavior or internalized lessons from the trauma where the person talks to themselves or have the ideas and the thoughts or wishes of dying and suicide or wanting to end their lives and suffering. But self-harm behaviors we classically view as externalized kind of behavior. And then some might turn towards addictions or self-numbing. And by addictions, we mean all kinds of addictions: food, shopping, social media, alcohol, drugs, whatever. Anything that can get us to numb that feeling of pain that we carry and anything that can make us avoid facing that pain if we do not process it. And now I'm gonna I guess I'm gonna move the talk or give it back to my colleague Heba to explain to us the stress response with the trauma.
So I second everything that you're saying, Rahaf. For sure, when there's an experience of an overwhelming pain, people try to avoid it in every possible way. And sometimes it gets so hopeless that they think of ending their life or having to seek substances to try and numb that pain. And in the Islamic context, people sometimes shut that down with it being haram, or these are haram thoughts, these are haram behaviors. It's important to note that we're talking about a mental health problem here. And so shutting it down in that way is not helpful or constructive. And we will keep you engaged all the way till the end with what to do in those cases, in the Islamic approach, in the compassionate approach. I won't reveal too much about how. But before we get there, I'm going to tell you a little bit about the stress response with what's happening with the brain in the context of all of this pain and trauma. So in general, we have the upstairs brain with the frontal cortex here, if you can look in the slide. And the prefrontal cortex is responsible for our executive functioning. And in this particular case, emotional regulation and fear modulation is a huge part. Usually this gets, we fully develop that in our mid-20s. So for children, they really haven't even formed that yet. And then the limbic system that you see on the right, that's where we have our amygdala, and we have the flight-fight response to danger and threat around us. So any traumatic event has a danger or threatening response in it because there's a really bad thing that's happening, whether it's a car accident or war or child abuse. So the limbic system gets activated. You go back here, your downstairs brain, the limbic brain, is getting activated by a threat, and it can no longer reach the upstairs brain, the prefrontal cortex, to get help for emotional regulation, to get help for fear modulation, to get help for rationalization, and even for things like moral thinking and decision making and being able to make good judgment and executive functioning. All those things are in your prefrontal cortex. So really going to a person who's having that experience and telling them to think rationally would not work, because first we need to comfort them and help them regulate their emotions. When people experience prolonged trauma, what's the neurological impact on the brain of trauma? The research shows that there's a biological impact on the structure of the brain and then the chemicals that are being released in the brain. This is a very biological issue here. So you get an overstimulation of the amygdala. It becomes enlarged in size. It becomes overstimulated, and makes it even more difficult to regulate. And then this is correlated with the person perceiving trauma and perceiving threat everywhere they go, and constantly being afraid and feeling pain. And there is an underactive hippocampus. And the hippocampus is usually very crucial for retrieving memory and distinguishing past and present memories. And so you find people with especially chronic trauma having a really hard time having a timeline between what happened before, what happened in their childhood, having memory gaps because their brain has been impacted. And you also find prefrontal cortex shrinkage. You actually find that there's a reduced neural connection with the amygdala, and a very difficult ability to regulate the emotions. Reflection in the structure of the brain that we're talking about. So I'll hand it back to Rahaf to tell us a little bit more about how the brain is going to get affected.
So thank you, Heba. The thing is, we're talking about all these like biological changes as a result of an environmental exposure to a traumatic situation. And what I thought was quite interesting that these changes occur not only because of like what people might conceive as a huge like traumatic sexual assault or like war or huge, like what one would think is a huge newsworthy kind of trauma. But these are studies that I found that really talk about changes in the brain as a result of emotional trauma or verbal abuse. So, for example, there is an event related potential study that showed that adversely treated children have cortical hypoactivation when viewing emotional facial expressions. So these kids do not really respond to uh, emotions or reading emotions in other individuals in the same way. They really have a hard time with reciprocity and therefore developing healthy relationships in the future because of this trauma that they experience, because of the maltreatment. Uh, Another study with the diffusion tensor imaging shows that there's a reduced white matter tract function resulting from parental ridicule and humiliation. And that's a study from Ohio that was published in 2009. Just, uh, just to think that sometimes parents, maybe with the intention of being humorous or funny, they might say something to a child, which is not uncommon in our community. Of they think it's funny or it's a joke, but a child views it as ridicule, as humiliation, and repeated exposure to that from family members, from the community, that can really affect how the white tract matters are functioning in the child's brain. Another non-clinical sample of children who had harsh corporal punishment was associated with reduced left dorsolateral prefrontal cortex. And that's another study from 2009 from Tomoda and Suzuki. Uh, Basically, they're saying even punishing children in a corporal way, in a harsh way, can really result in a reduction in their brain volume and therefore with their ability to develop and grow in a healthy way. And therefore, it affects their entire future. Now, uh, with this in mind, we have to really talk about how do we diagnose PTSD? Because we're talking about a sample of population where they might have reduced reciprocity. They might have anxiety like symptoms because they're hypervigilant. They might have performance problems in school, at work, or in various areas. Um, they might have reduced emotional expression or hyper expression of emotions, depending on how they deal with this activation with the amygdala. So now we know all of these. When DSM, that Diagnostic Statistical Manual, which is kind of like the reference, the big reference uh, in psychiatry started, it was basically collecting a group of observational symptoms so that doctors or psychiatrists can have a common language between them. And now we're in the fifth version. And we're still, unfortunately, miles away from really understanding what's going on in the brain. And we're still depending mainly on observational collection of data uh, and subjective reports. And it's important to note that in this context, that trauma has a lot of uh, objective experience of the therapist or the doctor or observation of the doctor or interpretation of the psychiatrist or the doctor of what the person's experience is. So they may not interpret trauma the way the patient interprets trauma. And I've seen that quite often in practice where someone might come with a traumatic relationship in their workplace or in their family context, and they have all symptoms that we of trauma, But because of the doctor not identifying that as a life-threatening situation or serious injury or harm, and therefore they do not give the diagnosis of PTSD. And that's interesting because that directs the way the treatment is, or the treatment approach is chosen for this patient. And that's I guess one of my personal observations. I wouldn't say critique, but maybe area for us to be mindful of in the future when developing the next DSM. That when we take away the autonomy of the patient and do not listen to the patient's experience and allow the physician to interpret it from their point of view of what's traumatic and what not, then we end up with less than an ideal situation, and therefore inaccurate diagnoses and treatment and prolonged suffering for patients. Well, that's the little kind of intro that I had with the DSM, the kind of love-hate relationship that I have with our guide. But nonetheless, to go through the definition of what we have so far, we have this exposure to a life-threatening event or physical integrity, something that affects the life or physical integrity of the person, whether it's a direct experience or witnessing a person in the event. We're learning about the traumatic event that occurs to a close family member or a friend, and then experiencing repeated extreme exposures to adverse details like the police or like frontline workers. And then we have the constellation of symptoms that we imagine develop as a result of this exposure. One or more of the following symptoms that kind of talk about reliving the event: intrusive, distressing thoughts, nightmares, flashbacks, dissociative reactions, marked psychological reactions, persistent avoidance to stimuli of the event, avoidance of distressing memories, avoidance of external reminders, or including people and relationships. And then we have the negative alterations in cognitions and mood associated with this exposure to the trauma, like inability to remember important aspect of the traumatic event, persistent, exaggerated negative beliefs about oneself, like I'm bad, I deserve this, persistent distorted cognitions because of this trauma, persistent negative emotions, fear, horror, anger, guilt, markedly diminished interest or participation in significant activities, feelings of detachment or estrangement, persistent inability to experience positive emotions, and then marked alterations in arousal and activity. And this is the discussion about the anxiety symptoms, the fight-flight response that Heba graciously kind of walked us through: being irritable, hypervigilance, reckless, have problems with concentration, sleep disturbance. As you can see, it's quite a prolonged kind of criterion that we have to go through with bits and pieces of everywhere, which makes the diagnosis not an easy one to have and not an easy one to remember for medical students, for residents, for doctors from other specialties who are not in psychiatry, are not constantly thinking of it. So we have to be intentionally and mindfully thinking of trauma, putting it in the forefront of our brain so that we can remember all of these, to ask about all of these, to screen for them. Now, the other pieces of the criterion that we want the disturbance to be more than 1 month, we want it to cause clinically significant distress, which is, again, this is an objection, kind of an objective view of the practitioner or the physician healthcare provider of like, what do I think is significant distress or social impairment or occupational impairment? Oh, you're going feeling miserable, you're still going. It's not an impairment. The disturbance is not attributed to other physiological effects or substance. Again, this is another tricky one because we know that a lot of individuals try to avoid these traumatic experiences by using substances and avoiding coping strategies. Now we have this piece with to kind of explain whether it's with dissociative symptoms or not, whether it's a delayed expression or not, because sometimes people do not show the trauma response for at least 6 months after the event, and then they develop it way after. With the dissociation piece, that we want to see something with depersonalization or derealization, and I'm sure many of you know what each one means. When one feels like a dream state, the other feels like the person is out of their body, and whether that's occurring in the context of a trigger or no trigger, whether that makes a difference or not in the treatment. Tricky stuff. Now, and that's part of why I think it's important for us to be talking about it collectively as a community, as healthcare providers, and as a community, a Muslim community, because we know a lot of our people in the community, friends, family, who might have a bunch of these kind of things here and there, but we really don't know what to do. What is this? Is it PTSD? Is it not? What do we do? And for us to talk about that in detail, stay tuned till the end of this presentation. So hopefully we can have some pointers. But now let's talk about why do we care? Why do we want to talk about trauma in such a way? Because we know it has huge effects, huge. It has effects in the present, effects in the future, the effects in the present on the individual, on the family, on the community, on the healthcare, and also on the financial and economical level. And future, we know with the intergenerational stuff we talked about, then we're giving our children, our grandchildren, less than ideal genetic expressions to work with and help them through the process of living. And now I would like to hear Heba walk us through the effects of trauma on the individual.
Yeah. Thank you, Rahaf, for sharing that. So I'm mindful to hear that still we might be struggling with my audio a little bit. So I'm very vigilant to hear the feedback. We'll give it another try. And if we're still struggling, then we'll do a tech break. But let me give it another shot. So the effects of trauma on the individual are really, really significant and can be. One particular study that stands out is called the ACE study, the Adverse Childhood Experience Study, which is one of the largest investigations ever conducted to assess the association between childhood exposure to traumatic stress and later life health and well-being. And the reason why we focus on childhood adverse events is because it really does affect the person the most when it's in the critical period, which is in childhood. And I'm seeing our team come online, and I'm wondering if the audio is still okay. So if you can hear me, let's do a 5-minute tech break, and let's come back at 1:30, inshallah. Okay, everybody will come back at 1:30. Thank you.
Hi, Shanza. Thank you so much for your question. Hello. Assalamu alaikum. Thank you, Shanza, for your questions and for your comments. Yes, you're absolutely right. There are huge gaps in DSM-5 diagnoses, and we really would like to see an improvement in that. And if you stay tuned till the end of this presentation, we have a few pointers. We have a few ideas that might help. Hopefully that can answer your question. And thank you for hosting.
If there are other questions, Rahaf, that you'd like to address, we could spend this time doing that as well, if you'd like.
Yeah, I thought maybe we can be proactive in that way.
Sure, let's do that. Thank you.
Sure. So
would you like me to tell you some of the questions that we've had? We've had 2 comments about the DSM-5 and kind of pointers around it. So that will be addressed towards the end. There is one question about the field of trauma and understanding that in different there are different cultural practices regarding silencing versus disclosure. So they want you to speak to whether the role of disclosure is addressed within Islamic tradition or kind of expectations around this within the Muslim communities.
Well, thank you so much for a wonderful question. And it's definitely an important one. And it's right there in the center of the treatment and in the center of all these hush-hush problematic behaviors in the community and the misunderstanding of the religious teaching. And we are definitely going to answer that within the presentation. If you stay tuned, you'll find that we have a slide specifically, or a couple of slides specifically towards that point. Thank you.
Thank you, Rahaf. Should we take one more?
Absolutely.
Okay. So the next question is about maybe using religion sometimes as an excuse to have like harsh parenting at times, even though we know very well that religion does not tell you like to use these methods, but some parents would use them sometimes, and this can be punitive and harsh. So the question is about the relationship between parents and their children, and when using that kind of harsh parenting style with their children, and how do you address that as part of trauma work?
Well, thank you for being so honest and kind of joining us in this conversation of what we have, unfortunately, as a common and prevalent challenge in the community of the process of parenting. And I think what is happening is this confusion between what we inherited culturally and what religion is, because there is nothing in Islam that says that we need to be harsh with our children or use intimidation. And none of the Sirat Rasul, none of the Sahabis' description of how he dealt with children, how Islam talks about children, how they're viewed as treasures, as joy, as a gift of God, as a manna from God. None of that goes with what we see, unfortunately, in the communities of how kids get maltreated, neglected, humiliated, punished, physically harmed, and some even sexually harmed, unfortunately. Uh, and, and I do see it as a huge problem because it's 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 a problem from a Muslim point of view that affects the faith and the spirituality of the younger generation, because it affects how these kids grow up thinking of their own community, because their representation of what Islam is their parents. And therefore, that kind of break in the attachment and the trauma in the attachment in their relationship with their parents kind of transfers to all their relationships with the community, with Islam, with God, with anything that represents or reminds them of the trauma and the attachment that occurred when they're younger. So that's one problem that we have from a Muslim point of view. The other problem is we have it from a healthcare worker point of view, from a mental health professional point of view, is these kids are growing up with all these predispositions to mental health problems, to physical health problems, to also problems with their relationship with us as healthcare providers and the relationship with us as Muslim healthcare providers. So there it's a huge thing, and it's definitely worthy of a conversation, and it's worthy of us having this time to talk about it, and definitely for it not to be the end but the beginning of the discussion, because we need to continue to have this honest discussion. We need to have more initiatives, more community involvements, and to represent ourselves and as Muslims in our community and outside our community, and to represent ourselves from a scientific point of view as doctors in the community of how this is not a good idea, why this is not a good idea. And I believe there were some practical, wonderful tips from the talk that was given by my colleagues, Dr. Arfin and Dr. Samah yesterday. I don't know if you were there for it, but it was wonderful. And I highly recommend that you refer to it for practical tips and points that you can kind of hand out to these parents when you talk to them. And I just want to highlight as well, it's important when we are trying to educate the parents to use a compassionate and non-judgmental, non-shaming, non-blaming, not guilt-inducing approach, but more of an empathic, loving, forgiving, enlightening kind of approach that embraces and holds them, so that they can have that embrace and feeling of containment and transfer it to their children. I know this was a long-winded answer to your question. As I said, I prefaced this by saying I really am passionate about this talk, and I'm sorry if it was too long. But
Thank you so much, Rahaf. Like, that was a great answer. Very detailed, and I'm sure everyone appreciates that level of detail. We are supposed to be going back to the talk right now. So let's see what is, we can't see your video, Rahaf, by the way, just to let you know. I don't know if you are off video.
Yeah, I went off because I think,
okay.
I said, let's take a breather.
Yes, that's fine.
Okay, breather.
So we will be going on shortly. I think Heba is still figuring out her audio issues. We can check the last kind of comment or question. And if there are any questions, please post them in the question and answer section so that we are able to answer them either now or towards the end of the session.
I think there's a question here from Bina Sayed.
Yes.
You have not?
Okay.
You want to read it?
Thank you. So, are we also discussing overcoming trauma or the word trauma, and what kind of implications are associated with it? So the example that they gave is trauma equaling kind of a long-lasting suffering, and someone who's done work to overcome this, starting to recognize it as something beyond trauma. What do we call it?
So thank you, Bina, for the question, and thank you, Samah, for reading it. So and sharing it with all of us. I guess we did touch on the definition of a traumatic event and what trauma means in the beginning, and we talked a bit about the different types of trauma. And now my colleague Heba is hopefully done with dealing this technical issue, and hopefully will lead us more into the discussion about some of the long-lasting and suffering studies that we know of, like the best and the biggest, the adverse childhood event studies, and information gathered from that study. And then I guess we'll talk a bit more about what to do, what the treatment is, what the solution is. So please stay tuned, Bina, and I hope you enjoy the rest of the talk. Thanks for your question.
Thank you, Rahaf. So I see Heba is back. So I guess we are ready to restart our talk. So Heba, if you can unmute, or yeah.
So we're doing a very creative thing where I am on audio on the phone and visually on the laptop.
Whatever works.
So if everyone can hear me?
Yes.
Okay, perfect. And again, I'll be paying attention if there are any further tech issues. So we were talking about the ACE study, and as mentioned, it's the largest one correlating the traumatic childhood events with a traumatic response later in adulthood. And okay. Can you see my screen?
Yeah, we can see it.
Okay. So in adverse childhood events, no, it's not working. It's stuck.
Let's have some advance, perhaps. Do you have the copy of the slides?
Yes, I can share my screen.
Why don't you take a few more questions, Rahaf, while I get the screen shared by Sama?
I think Sama has it shared.
Issues happens with technology.
It's okay. It's shared now. I think you can just
we're going to take a couple of minutes. So in the meantime, why don't you take some questions from our attendees?
Definitely. Samah, do you want to read the question?
Yes. So someone is asking if you will be able to send your contact information, or will it be provided at the end of the session?
I'm happy to send the contact information. I don't think we added it. I think that was kind of the challenge of having two people who are very passionate about the topic and have lots to say and add. So we spent a lot of our time making sure that we make this as beneficial as possible.
Okay. So then maybe we can add that to the slides if they will be provided on the website later.
Yeah, for sure. Thank you.
Okay. Perfect.
Sama, if you're pulling up the slides, I can do the questions.
Thank you.
Like. Yeah. So the next question is about, it says, Jazakallah khair, doctor, I always translated and interpreted the word for word, what is, oh, I think you've already done that one. Sorry, so it says, I am quite passionate and committed to this critical area of trauma, vulnerability, violence, and how the Islamic worldview is on violence. Have you already answered this question?
Emailing them. Sorry.
Our humanity and understand that impact of violence and trauma in our humanity. It is critical and imperative to discuss and educate on trauma experiences and multiple intersections in a non-judgmental, courageous, and empathetic with brave leadership, equity, compassion, and justice. So it sounds like it's more of a comment, and I think you would agree with all of those statements.
2 thumbs up.
Yeah. It says, if one question is just to actually share your studies of the trauma in Muslim countries, the traumatic experiences of children and adults. So the studies that you were able to look at, if you could share the references for that. So those will be in the slides. Yeah. There is a comment about needing to take courageous and brave leadership on trauma and violence in our communities, how to lead together. Please give your recommendations and action plans to take action now.
Okay, so how do we lead together? That's a really powerful way to ask this question, and I think we've got the last portion of the presentation dedicated towards that specifically, and maybe we'll give this whole technical situation a bit more time. And once, hopefully, inshallah, we get over it, we'll get to that answer. And
sure, yep.
Of course, that's and if there is more that you feel like maybe proposing or wanting to initiate, we'll be happy. I'm sure Heba and myself were both happy to kind of join in the conversation and lean in with you.
For sure. Okay, perfect. Another question is about how to navigate with adult Muslim clients who have developmental traumas that were inflicted by parents, especially if it's severe, while also keeping in mind the significance of parenthood in Islam. Patients who suffer from trauma in their childhood are angry at their parents and might be resentful of them and want to distance themselves from them. But at the same time, they feel guilty because of the huge significance Islam gives to parents.
Yes. Yes, this is so so critical, and it is one of those areas where we, I would say, in general, we follow the basic principles of being compassionate, being patient, going with the patient's lead, being non-judgmental, and breaking for grounding and breathing and calming ourselves and the patient down, and then allowing them to share as much as they feel like sharing whenever they're ready to share, and providing them with empathic listening, active attunement, validation, and then and not really take the role of the Muslim kind of passionate kind of advising person of like, oh, you need to forgive, you need to do this, not really directing and ordering, but more of listening and being empathic and passionate. And like there are details of how we can tackle this from different roles, but the general view from any aspect, as a sister, as a friend, as a doctor, as a mother, as a daughter, as an imam, as a religious scholar, the principles are always of being open, non-judgmental, compassionate, patient, empathic, and validating are always there. And of course, the self-preservation, the important piece of also keep in mind your own safety and break for a breather, break for your own mental health needs, and come back and pace it as you feel comfortable and the person who suffers the trauma feels comfortable.
Yeah, and I think, just along the same lines, I think the question was asking too, like, because in Islam, we're often pulled to just kind of respect our parents despite really challenging circumstances that could have happened with parents. And I think there's been lots of good, talks by religious scholars as well addressing this issue where actually, children have rights over their parents, parents have rights over their children. But if children's rights were not met and that there is lingering significant trauma that impacts them, then perhaps a repair is not possible. And perhaps it's not possible to actually have an ongoing relationship if there is significant sexual abuse that happened or physical violence or lots of things that do occur in our community. And so we have to be really aware of these things and not kind of make blanketed statements about how a person may be able to repair that relationship, because in some cases it may just not be possible and not be what's really recommended even.
Exactly. And repair doesn't necessarily mean healing, and healing doesn't necessarily mean repair. The focus of the trauma work is to help the person heal, and healing does not necessarily mean repairing the relationship with the person who caused you the trauma. You're absolutely right. And there's more talk about this. You'll find Heba did a wonderful job in kind of researching the literature and like providing lots of tidbits and points, hopefully in the presentation to come. So stay tuned.
So maybe we'll take another question while we're having her come on. And as soon as she comes on, I will switch over to her. So it says, I have a question regarding psychological trauma in a spouse. How do you deal with it in helping them accept it while at the same time making sure I'm able to keep my own emotions in check and not become traumatized in the process? I'm talking about work-related trauma for the spouse.
So that's definitely a tricky situation when any of us experiences trauma and suffering. It's not an easy journey, and it's definitely not an easy journey to watch a loved one or like be part of a relationship where the other person is suffering and struggling and wanting to support them while also wanting to remain healthy. I think again the general rules of like make sure that you are safe, that you're grounded, that you're taken care of. Put your mask on first before you can assist others, like an airplane. And then, whenever you are engaging in a role of trying to help someone, always come with an relaxed, flexible, open, not judgmental, accepting, patient, and accepting the person's pace and their willingness to talk about it, and also accepting your own and respecting your own boundaries of how much is too much for you, and kind of trying to lead that path because it's so individual of how much a person can take, and you would be the best expert in how to maintain your own well-being in that relationship while offering support, not judgmental, empathic, compassionate, also helping them reach out for professionals if they're at that point, or maybe bringing up the topic of reaching out for professional support and not necessarily kind of pushing for it. Well, thank you.
Can everyone hear me now?
Yep, perfect.
Perfect. So I want to tell everyone thank you for your patience while we're managing all these technical supports. I am personally having a traumatic response to all the technical problems we're experiencing, but I am resilient to keep going right through them. We're gonna have someone else do the slides for us to try and see if that helps with the audio. So again, your feedback is appreciated. You can just keep letting us know if you can see the slides and hear us. So we were talking about the adverse childhood events, and what we discovered is that both positive and negative childhood events really do have a pronounced effect on memory. However, violence and victimization is most pronounced, and this is, if we go to the next slide, you'll see in the pyramid that the impact is anything from social conditions to disruptive neurodevelopmental impact, like we've discussed, social, cognitive, all the way to diseases like actual physical impact and early death. The three types of ACEs include abuse, which is physical, emotional, sexual, neglect, also household dysfunction, which is like divorce, substance abuse, a mom that's maybe treated violently, an incarcerated relative, or a person in the household who has a mental illness. And this is not something that we talk about as a Muslim community. In fact, I, as a person, identify as a person with a lived experience of a family member who does have a severe mental illness growing up. And that is one of the things that I would identify as having an adverse childhood event. But this isn't something that we talk about as a Muslim community. It is highly stigmatized. And even in my social networks, I would meet people that I've known for 5 and 10 years who had never shared such a thing with me because it is highly stigmatized. And as healthcare providers, because today I know that a lot of attendees are healthcare providers, are frontline workers, people tend to see us as the go-to people for services. So sometimes we forget our own experiences, which shape us and impact us. And it's important that people and ourselves, that we see ourselves in a holistic way, and that we do have those experiences ourselves. The behavioral impact can be like Rahaf said, you know, the smoking, alcoholism, drug abuse. It can also be missed work, difficulty concentrating or staying on track. There's definite physical and mental health impacts, increased suicidal attempts, diabetes, heart disease, cancer, stroke. It is associated with almost every major health illness later on in life. The prevalence of ACEs is also very interesting to see. There's definitely a gender effect. In terms of emotional abuse, it is higher for women than it is for men. For physical abuse, it tends to be a little bit higher for men than it is for women. For sexual abuse, it is higher for women than it is for men. And in this particular study, reported at 24.7% for women and 16% for men in about just under 10,000 women and just under 8,000 men in the participants. And this is considered to be underreported because this is a very stigmatized topic. So this is just to give you an appreciation for how common these problems actually are and how much we don't talk about them and the effect people around us every day. So Rahaf, you're muted. There we go. Chugging through.
Well, thank you so much for that quick kind of overview of the ACEs study. And we were talking initially, we utilize the ACEs study because it's one of the biggest, more known, well-studied kind of effects of trauma and their effect on the individual person. So to look at how they affect an individual person, we look at the prevalence here. Those individuals who have adverse childhood events of a score of 1 have a certain risk of developing ischemic heart disease, stroke, COPD, diabetes, sexually transmitted diseases, and that number increases more and more the more adverse events the person experiences. And you'll notice that this effect is not only on the person's physical health. You'll notice that also in the next slide, we discuss or we have a reference for the prevalence of mood disorders, anxiety disorders, substance abuse, impulse control disorders. And these are like huge kind of dragging down effects a person deals with for the rest of their lives, physically feeling unwell, psychologically feeling unwell because of the trauma they experienced when they were children. Now, it's important to bring your attention to the fact that having more than one traumatic event or adverse event in childhood does not work as a cumulative kind of dose-response relationship. Not just if you have one, you'll have and then you have two, then it's the accumulation of the two risks together. No, actually, they have a synergistic effect. Having two ACEs, they have more effect than the addition of the two risk factors. And that's obvious in men as well as women. And we have examples here for individuals who have risk factor of having substance abuse in the home or mental illness in the home. If you have both together, then the risk factor actually is much higher than having either one or two, or what you would expect from the addition of the two. Now, this slide kind of talks about how adding these things together can kind of take us to, unfortunately, a disrupted neurodevelopment, social and emotional and cognitive impairment, problems in health and risky behaviors, psychological problems, and then eventually an early death. Unfortunately, if you look at the prevalences, you'll find that 67% of the population have at least one adverse childhood event. And there are more and more, and you'll find the more there are, the worse the health of the individual is. Now, we move to child maltreatment, where Heba is going to tell us all about it.
Yeah, and to wrap up with the ACEs, it's actually considered the single most neglected public health issue in Canada because of how much it affects both healthcare outcomes, physical health outcomes, and mental health outcomes. And so to dive deeper, we're going to focus a little bit more about how it affects children. And so the World Health Organization specifically defines child maltreatment as the abuse and neglect of people under the age of 18. It includes physical, emotional, sexual abuse, as well as neglect. And then as well as, using children for sexual purposes, or pornography, sex trafficking. And then the types of abuse that we talk about are, again, not talked about in the Muslim community. And I think neglect is especially a very common one that is often dismissed even when we do talk about it. This is a very interesting study that I found reflecting child abuse in Saudi Arabia, which I was very happy to find because this is a very stigmatized topic. So the fact that Saudi Arabia is becoming more progressive and giving attention to this topic is really great. This particular study had just under 3,000 participants, which is a 34% response rate from the people they reached out to. And again, they think it's underreported. However, 48.3% reported neglect, 73.8% reported psychological abuse. That is really high. 57.9% reported physical abuse, again, extremely high. 15.5% reported sexual abuse, and that is probably underreported. And 49.6% reported exposure to violence. So this gives you an idea of how many traumatic events people are experiencing and going through. When we bring this topic up, we need to bring up the Islamic context for the rights of children, because in the Muslim community, we often talk about the rights of parents, which is very important, but we don't balance that with talking about the rights of children. And this imbalance creates a real problem in the way that people are represented in our communities, and it creates a gap that is not healthy for our community. I think that scholars as well can really pay attention to this issue, making sure that the rights of children are well represented, especially that they can't speak for themselves. There's a rising trend for what is called uquq of children by parents. Uquq is sort of the word that refers to disrespect or maltreatment or detriment of rights or even a sacrilegious act. And it comes from the word of origin aq, which means to split or sever. And it refers to the very sacred bond between a parent and a child and like disrupting that bond. And we often hear about uquq al-walidain, disrupting that bond with a parent where the child is the one that's, you know, neglecting the parent, not giving them their rights when they're older, not looking after their health, maybe not providing for them financially. But this has to be also looked at from the other lens, from the other perspective when the children are young, and making sure that we're not doing uquq to our abna, to our children when they are young. And we're going to discuss in the next slide how to do that. The Islamic context of where this came from was an old person who came to Umar ibn al-Khattab radiallahu anh, and complained about his son. And Umar ibn al-Khattab summoned the son and asked him if the accusation was true. The son asked him, well, what of the rights of children? Do children have any rights? And Umar ibn al-Khattab told him what the rights of children are. And the son said, I haven't received any of these rights. In fact, my father has called me Garan, which is an insect. Like he even named me after an insect. And he has not been good to me, and he hasn't treated me, and he hasn't given me nourishment and parenting, and he haven't done all those things. And so Umar ibn Khattab radiallahu anhu told the parent, you have done uquq to him before he has ever done uquq to you. So uquq essentially is the lack of being a role model as a parent. If there's behaviors such as lying or yelling or hitting a spouse or anything that compromises Islamic values or morals. Lack of involvement in upbringing. It's not sufficient to just pay money to bring up children. You have to be involved with quality time, with an attachment, with a bond that's nourished. Neglect, like we mentioned, physical abuse, hitting of any kind or bodily harm, or denying medication or treatment. Harsh treatment, which is unfortunately not uncommon in the Muslim community, being overly critical or dismissive. Guilt tripping, emotional blackmail is a common one that comes up a lot. An authoritarian parenting style, differential treatment and favoritism among the children, emotional or verbal abuse like humiliation, degradation, or name calling, or harmful da'wah, like saying, I'm going to do da'wah on you as my child. I'm going to pray that you receive a harmful da'wah. And abuse of power is also a really common one, where you see the parent thinking that they have ultimate power over the child, even asking them for things as far as divorcing their spouse or doing things that are harmful to the child. And then there's a very, unfortunately, uncommon one called spiritual bypassing, where religion is used to bypass the real problem at hand, to ignore the problem. And this is unfortunately quite common in the Muslim community as well. So for example, we would not address a mental health issue and just say, pray more or read more Quran, or we would not take responsibility for a problem that happened and say, oh, just please forgive me. No, we still have to take responsibility. We still have to provide mental health support coupled with as well, spiritual practice. So we have to do both. We can't use the spiritual context to ignore the problem at hand. Having said that, parenting is the hardest job on the planet. It is not easy. It is not inherited. You do have to proactively learn it and introspect and reflect and constantly adapt to model yourself. And you will make mistakes because we're human beings, and that's okay, as long as we're constantly learning from them. So just to briefly summarize, what are the rights of children in Islam? Rights to basic needs, financial support, shelter, food, Islamic and moral upbringing, being treated fairly, being treated with guidance and advice, right to education and being motivated, right to kindness, and right to being involved in a dialogue and respected. Sometimes we don't give children the respect that they should have. They are still human beings and we should still respect them.
Exactly. And now we go back to, I guess, continuing about the discussion about the effects of trauma. We mentioned the effects on the individual. We used the adverse childhood events as an example. We talked about the Islamic context, and now we talk about the effects of trauma on the family. We know experiencing trauma can lead to disruption in the attachment and leading maybe to unhealthy attachments. Or the worst of them is the disorganized attachment style. It causes relationship instability. There are higher rates of domestic violence, higher rates of childhood abuse. There are high rates of divorce. There are higher rates of imprisonment. And these are data kind of pulled from the ACEs studies. And then there is a discussion about domestic violence, which I know that we were talking about in the question and answer period. We know that unfortunately there is a high prevalence of it in our community. And I believe Heba will talk briefly about the Islamic context.
Yeah, for sure. Unfortunately, domestic violence is another topic that's very taboo in Muslim communities that we don't talk about enough. Statistics in Canada is that almost half of those who experience spousal abuse report recurring incidences. And there's very much lacking research in Muslim countries, unfortunately, but it is well acknowledged that it is a common problem and that there are high rates of domestic violence. I just wanted to go to the next slide to clear any misconceptions about how spouses are supposed to treat each other. So the Prophet's last word, sallallahu alaihi wasallam, before he passed was "Istawsu bin nisa'i khayran," which means his last wish for people to highlight what is important was an emphasis on treating women with kindness and protecting their rights in Islam. And he specifically addressed fathers and brothers with being kind to the women in their lives and making sure that they're given their full rights, and that this is part of their duties as men to make sure that they receive their full rights. And so if you keep that in the back of your mind, like this is the Prophet's last wish on his dying bed, this is his last wish. And in the Quran, we know that an ayah that's very commonly misunderstood is the one that goes, Bismillahir Rahmanir Rahim, الرجال قوامون على النساء بما فضل الله بعضهم على بعض. And the first part of that in English is men are the supporters of women with what God has preferred for some over the others. And another translation for this ayah is that men are superior to men, which is unfortunately a misguided translation. And God has created people all equal, and how we are differentiated with how God sees our piety or righteousness. And so with that context, I think the rest of the ayah also points out boycotting when a spouse, particularly a female spouse, is not being a good spouse, which is the word idrabuhunna. And that word is again used as hitting instead of boycotting. These are translations that have been debated by many scholars, but I ask you to consult your heart with the next ayah, which says that of his signs that he has created of you, of yourselves, spouses that may find rest in them, and he has made between you amity and mercy. Surely in that are indeed signs for people who introspect. So God is also putting the words for you. If you are introspect, if for spouses, you're supposed to have mawadda and rahma. How are you going to have mawadda and rahma if there's physical violence between you? That is not a solution for anyone. So next we'll talk about the effects of trauma on the community, and I will let Rahaf have that.
Thank you, Heba. That's truly needed to have out there so that we can discuss and understand Islam and maybe correct some of the misunderstandings out there. Now we know trauma affects the community in a way that it lowers the educational level, lowers the occupational attainment, increases the social service cost, increases the medical cost, and shortens the lifespan. We have here from the ACE study a slide showing how absenteeism, financial problems, job problems all increase with the increased adverse events that a person was exposed to as a child. Then we have the financial cost of trauma. What does it cost if we do nothing? This is from the US, and we find that it's 1.8 million per year per victim, in 2014. That's just like to think about how much each person is costing the system between the cost of healthcare, cost of mental health care, the cost, the lost productivity, the social service cost. And then we have yet another slide that kind of talks about the lifetime costs for all 2014 first-time maltreatment victims is about 5.9 trillions. And we'll be happy to include the resources with the presentation. Now, the next slide that we're going to talk about is the intergenerational effect and the cycle of trauma. Now, we've talked about how we kind of have the environment affecting our genes and how we give that unwanted gift to our children and grandchildren in by inheritance. Now, we also know that the cycle of trauma goes that, for example, a child is exposed to in ACE or ACEs, then they go on to have a response or coping strategy, including perhaps aggression or depression or school problems, and then they go on into adolescence where they get re-victimized. They have more psychological problems, more school problems, maybe school dropout, and then more maladaptive coping, substance abuse, and then they end up as adults themselves, where they end up having becoming parents, having domestic violence, and again, psychological problems, poverty, and the cycle continues and continues. And we have to, at one point, as a community, stop and say, hey, how can we stop the cycle and break it? And now we we have to acknowledge that we cannot do this as individuals. We have to collectively, as a community, come together to tackle a big problem that's multi-generational, that's cyclical, that's multifaceted. And that's why it's helpful to kind of look at things from the Muslim community context, because we are in the right place to talk about this now. So, and I'll give it to Heba so she can share with us.
Yeah, so it's really important to note that being part of the Muslim community will increase our sense of resilience because our collective sense of belonging does increase our social support, does increase our ability to overcome adversity. It's an asset in addition to our individual resilience. And I'm just going to rush us through the next few slides because I do want us to get through to the video that we created right here for you. So the slides that we've created have been done with the support of Imam Isa Al-Hajj Hussein from Saudi Arabia. He has a bachelor's degree in Islamic studies from Mecca, and he is the founder of the international Dawah organization called Muslim Voice for Peace and Reconciliation, as well as Samuel Schroeffer, who is the founder of Muslim Voice for Peace and Reconciliation as well. He's been a pastor for 25 years. He has reverted to Islam 7 years ago in Mecca, Saudi Arabia, and he's done amazing work So without keeping you further, I'm going to ask if Sama can play us the video so you could see their role play. So first we're gonna play a role play with someone who comes to an imam who is struggling, and we're gonna have a non-trauma informed response that is likely to harm the person. And then in the second role play, we're going to use the compassionate response of trauma that is likely to support the person.
I'm not sure why I'm here. I just feel like I want to kill myself. Life is just so hard. I mean, my boyfriend broke up with me, and my brother found out I had a boyfriend, and he hit me, and took my social media accounts and stopped me from going to school. And now I'm locked up, and I don't want to live anymore.
Fatima, your brother is right to be concerned about it. Parties, boyfriend-girlfriend relationships are sinful. If you act this way, you will have a bad reputation. By dressing and behaving in this way, people will think badly of you. You can't correct one sin with a bigger sin of suicide that would remove you completely from Allah's mercy. If you kill yourself, you will be doomed in this world and in the next. You will bring shame upon all your family and community. Have you ever considered your actions will affect your family? Your parents will be doomed. The men in your family are your guardians. The Prophet Muhammad, peace be upon him, said, "A man is the guide of the people of his house, and he is responsible for his children." Fatima, you are like my sister. Instead of this, you should be listening to the Quran and praying.
Well, Fatima, it sounds like you're going through some really tough times right now. I'm really sorry to hear that all this is happening to you. You did the right thing by reaching out to me, and I'm glad that you're talking to me. That's the first step. I hope that you don't hurt yourself. We all make mistakes in life, and God is all forgiving and He's all merciful. The Prophet Muhammad, peace be upon him, says, all of Adam's sons are sinners, but the best of sinners are those who repent. There's always a way out. These troubles will pass. Allah says, after patience comes ease. Before we can resolve this problem, you must first take care of yourself. So I want you to consider reaching out to a doctor or a professional counselor. I can help you find one, and I want to support you as you're going through this. Now let's make sure that you're taken care of. Do you have a safe place to stay?
I called my friend, and I can go stay with her.
Okay, do you still feel like you want to end your life right now?
Not right now, but when I'm alone at home, I have those thoughts again.
Okay, Fatima, if you have those thoughts about hurting yourself again, call 911 or go to the nearest hospital emergency room. If you have a hard time, you can call Nasiha or 211 or even come back and talk to me. I'm here. I'm your friend. My final advice to you, Fatima, know that Allah loves you and that He cares about you. And I pray that this time of hardship passes and that your life improves.
So compassionate, mashallah. So the two people that you just met are Sam and Imam Isa. They have been so gracious as to help us prepare this video, and they are not professional actors, and they have done their best in trying to apply the trauma learnings that we are trying to incorporate.
Yeah, and I'm mindful of our time, so I'm just gonna dig right back to this. So I know at this point it feels like the issue is overwhelming to some of us because it's quite big, and I want to take this point of time to remember a hadith of the Prophet ﷺ, where a man asked him, O Messenger of Allah, should I tie my camel or trust in Allah? Or should I leave her untied and trust in Allah? And the Prophet, peace be upon him, said, tie her and trust in Allah. So we should kind of use that as our guidance and trust in Allah and believe that all these traumas that we experience as individuals, as communities, have a reason and have a trust in Allah, and yet be active. So what do we do? What can we do? I like to call this the ABCs of trauma, which to all doctors, I'm sure, rings a bell from their surgical training. But this is the psychological ABC. So A, we would like to be aware of the situation, be aware of the traumas, the risk factors, admit and acknowledge, validate when we hear about it from our communities, from our patients. B, we be with, be there for, we provide containment to the person who's sharing with us the trauma that they have. We stay with them, be present, actively listening. C, compassion. Be empathic, be kind, be patient, non-judgmental, like this lovely dinosaur who's saying to the other one, you're not a bad person. The trauma caused you to act this way. And D is the decipher and differentiate. Decipher what is the trauma response, what is helpful, what is not, what is my role, what is the role of the professionals. Help the person in a way that is mindful and through differentiating what's the next step. And that ties in wonderfully with being effective. How do we become effective in helping ourselves, our patients, our communities? So we start by ourselves because that's part of the Islamic teaching, that one has to be responsible for themselves and change in themselves what they do not like before they try to change the community and influence change in others. And how do we do so? By self-compassion. We have to practice self-compassion, patience with ourselves, daily mindful practice, and also seeking help. Daily mindful practice, I would like to highlight, interestingly, that the research shows that if we do this mindful, introspective, quieting down the voices and reaching down within ourselves, is quite an effective way of improving symptoms and improving function, and changes actually the genetic transition or the genetic coding of trauma response. And interestingly, it's recommended to do it 5 times a day, which is at the very least, which is kind of the number of times we have to pray as Muslims. The other aspect is to utilize our belonging to this Islamic community, to the faith, in helping us find meaning in the trauma, find resilience, spiritual connection, religious practices, a sense of community engagement. And with that, I would like to mention that in Islam, there's a hadith from the Prophet ﷺ, where he says, no fatigue, no disease, no sorrow, no sadness, nor hurt, nor distress befalls a Muslim, even if it were the prick he receives from a thorn, but that Allah expiates some of his sins for that. Meaning, ما يصيب المسلم من نصب ولا صب ولا هم ولا حزن ولا أذى ولا غم حتى الشوكة يشاكها إلا كفر الله بها من خطاياه. God hopefully helps us find meaning in these difficulties. So the other ways we can deal with trauma, I know I received some questions about this. As physicians, we need to be trauma informed. We have to have trauma at the forefront. We have to be screening for it. We have to be identifying risk factors. We have to identify the risk in our patients, assessing the risk of suicide, self-harm, risk of risky behaviors, impulsive behaviors, also coming up with a safety plan for the individuals when they're distressed, and referring them to someone who is capable and trained to help them, sending them to immerse, sending them to psychiatrists, sending them to therapists.
Rahaf, I just wanted to interrupt and say that you have 5 minutes left.
Inshallah.
Inshallah, we will get there. We're doing our best. And if we were unable for some reason, please forgive us and reach out to us. We'll be happy to answer your questions. So physician and healthcare professionals, we talked about the different ways to screen. We talked about the safety of planning. And this is a very, very important point that we wanted to highlight here, that we should avoid re-traumatization. And that happens when we ask the patient to tell us about their trauma without really offering the containment, the safe environment to hold them and allowing them to go with their pace, but rather force them and ask questions where they get re-triggered, re-traumatized, and we do not have supports, and there we go, time's over, goodbye. And we send the patient feeling worse when they left our office than they did before they came in. The patient may feel misunderstood, and their experience invalidated, their trauma response cycle did not really complete. So they end up feeling overwhelmed, ashamed, and blamed, and losing faith and trust in the healthcare system. So please, my colleagues and whomever is listening to us today, just be gentle with ourselves and gentle with everyone we talk to when it comes to trauma, and not poke sticks in beehives. Unless we know how to handle the situation and we are safe and the person with us is safe. The core principles of being trauma-informed, as we said, acknowledgement, authentic recognition, safety and crisis intervention, respect, trust building, containment, giving control to the individual. This is another important aspect that we should, whenever we can, offer options, give a sense of control, give that person their autonomy back, because that's part of the psychological effect of trauma. The person ends up losing their autonomy, and part of that re-empowering process is giving them options, letting them choose, being compassionate, being an active listener, validating the feeling, even if you do not think the situation is quite that traumatic and you do not agree with their version of events. Validate their feeling, not the event itself. Strength-based and person-centered, of course. You should understand the triggers, you should understand the hyperarousal response, you should understand your limitations as a service provider. And not all of us here today should feel like they need to roll up their sleeves and go ahead and be trauma-informed caregivers, meaning they're going to provide trauma care and they're going to help everyone. Maybe we can't. Maybe we need further training. To this day, with, I would say, years of training, I still find cases where I am unable and I have to rely to my community, my colleagues, refer, brainstorm, and acknowledge. It's helpful when we acknowledge to our patients that this is beyond my scope. I really want to help, but I can't at this point. So I'll send you to someone who might be able to do better than I did. Knowing when and where to refer, which is important to know your resources where you are, and reducing the stigma, maintain the confidentiality and the trust of your patient, and instill hope. Instill hope and resilience. That's very, very important, because we cannot ask about all of this and talk about all of this without really remembering that there is hope. Things do get better. And I believe Heba will talk about the triphasic model of trauma treatment.
Yeah, let me just quickly get through the next couple of slides.
Okay, so I'll give you 1 minute and then, okay.
So as therapists, we have multiple types of therapies that we do provide for trauma therapy. The most researched and evidence-based are cognitive behavioral therapy and dialectical behavioral therapy. The triphasic model of trauma is very important for healthcare providers to learn about as well, in order to understand that there are 3 phases when we do provide care for people who have experienced trauma. The first phase is safety and stabilization. So we can't process the trauma or go into the detail or the story of trauma like Rahaf was saying, because it would be re-traumatizing and unhelpful, until we have done the safety and stabilization with them and help them learn healthy coping skills and adaptation. The second stage would then be the processing of the trauma and ensuring that we do that at their own pace with containment. And then the third stage would be working towards recovery and rewriting the narrative of their life from a strength-based perspective and giving them agency and helping them rediscover the empowerment in their life so that they can choose to do with their life whatever potential they have in it. And if we go to the next slide, I also wanted to highlight, just for the imams as well, so we're not leaving them out of our discussion here, that this has been prepared for them. It's called the CARE guideline, because I know that for imams, they would be very overwhelmed if they haven't had training of how to address someone with trauma. And you don't need to get into the details with someone who have had trauma. All you have to do is to connect with them. So this is what the CARE is. C is for connect, assess risk. By assess risk, we really mean just see if the person is telling you that they're having thoughts about wanting to end their lives, or that they're being aggressive, or that they're harming themselves in any way. And if that's the case, you can collaborate with them to call 911 or go to the nearest emergency. And then reassure them that this will pass. This is very important. The R is for reassurance. And E is for encouraging professional support. Connect them with the family physicians and the therapists that we had just mentioned. And if you are a family member, please take the advice that we have been sharing throughout the presentation of just being compassionate and empathic. And I think maybe we'll take one more question if the time allows.
Sure. So let us, I just want to thank you, first of all, thank you so much for this talk. I know there was a lot of glitches, and you have so much to offer and so much to talk about. So one thing that we were discussing is actually having Rahaf and Heba record this offline. And then we would post the lecture without glitches onto the website so that all the attendees today can have access to it, because we know that we have so many questions to answer and everyone is eager to hear more from you. So the second thing I wanted to acknowledge is that we had a Dhuhr prayer kind of break that was in the middle of all this, and we weren't able to kind of fulfill it, unfortunately, but I still hope that people were able to pray Dhuhr while we're having all the glitches, and we really apologize for that. The other thing that we wanted to say is that the schedule is going to be a little bit shifted. So our next talk is going to start at 2:45, and it's going to go until 4:05. It's going to be, yes, okay, thank you for sharing that. And then we are going to have the last talk on Islamophobia and mental health be have a break in the middle with the Maghrib prayer break. So we're going to go until almost 6 o'clock. Our next talk is going to be perinatal mental health in Muslim women by Dr. Farah Islam, and it will start at 2:45. So what we can do is, if Heba and Rahaf would like to answer questions right now while people take a break, we can have that happen until 2:45 or so.
That sounds great.
Yep.
And I want to thank all the attendees for staying with us through this traumatic event that we're having with the technological problems and overcoming them and staying resilient. And we welcome the questions as we collectively learn together from this.
Yes.
I absolutely echo that. Thank you everyone for sticking with us. And maybe I just wanted to say one last thing, because I'm mindful that we had to rush towards the end of this presentation. And I am aware that we said a lot. and I'm aware that we didn't have enough time in between to break, to breathe, to process together and bring ourselves down. So if you are here still, take a minute just to breathe in, breathe out, and bring yourself back. And focus on the fact that there's hope and we're resilient. And resilience is a proven way to overcome trauma.
Thank you very much. So we will take only 2 questions from the questions that were in the chat. So one question is around, do you believe that medications have a role in the stabilization phase? If, let's say, the person has severe major depressive disorder, do you also, what are your thoughts around the rapid eye movement treatment for Muslim patients?
Do you want to go first, Rahaf?
So yes, I do believe that the medication has a role in helping people stabilize in the beginning. If they are so sleep deprived, for example, that they haven't been able to sleep, there's no way that you can work with trauma processing and helping them kind of reclaim their narrative. If they're sleep deprived, we have to tend to the basics. We have to make sure that they're safe, that they are able to sleep, that they are able to get out of bed, that they're able to take care of themselves, eat. Personal hygiene, all of these are important. So yes, absolutely, stabilization phase, do whatever we have to do to get the patient to maintain the bare minimum. And I believe there are studies I know our studies are not ideal in psychiatry, actually in all of medicine. If we're just hard on ourselves in psychiatry, in all of medicine, nothing is ideal because life is not ideal. But there are studies that show that there are lots of medications that are recommended, first line, second line treatments, the SSRIs, SNRIs, and so on. So yeah, short answer is yes.
Thank you.
The literature does support that both psychotherapy combined with medication, especially in the beginning phase, is quite helpful for people to get treatment. I, as a person who's a psychotherapist, when I work with psychiatrists, with patients who have been taking some medications, I'm very grateful for that, because when we first start doing the trauma work, it can be very, very difficult. And there's usually a setback that the patient experiences or the client experiences before improvement or relief. So in that period, having the medication is sort of like a pain relief that they can rely on before we can actually get to processing and before they can experience a psychological relief. So I do, as a person, think that as a therapist, think it's very helpful to the clients.
Thank you for answering that question. One more question is around setting limits on behavior, and that every society must set limits on behavior. So how do we do this without placing negative emphasis on those undesirable behaviors? So treating them as shameful has been a common historical approach. How do we do this without anyone perceiving them as being judgmental? Is there some judgmentality required? So maybe Heba can answer that question.
So I don't mind giving a go. I think if you are really trying to put your trauma-informed care hat on, you're going to focus on the person first, and then other parts of the person, like behavior. So if we're focusing on the person first, we're going to focus on the person's pain. If you see a person who's set on fire move around and scream, you're not going to be like, this person is screaming out loud and disturbing the crowd. This is not okay behavior. You're going to focus on their pain and the crisis that they're experiencing. So similarly, someone who's experiencing a trauma is experiencing that pain, but it's invisible. And so we have to focus on that pain that they're experiencing without judging them and providing them with pain relief before we offer suggestions like, such behaviors, they need management. We need to have consequences. We need to have boundaries when doing it in the most compassionate and the most supportive way possible. And yes, without judgment, without shaming, without trying to tell the person that they're wrong, but always telling them that they're ways to improve. There are ways to be better.
Thank you so much for answering that.
Beautiful answer. May I just add something
Sure.
from parenting? Quick. It's always helpful to say that this behavior is not good, but you are a good person. Just highlight that the behavior is not acceptable, but the person is definitely acceptable and loved and wanted. Thank you.
Thank you so much. So there are many other questions, and there are a lot of wonderful comments about how you two did an amazing job, even given the circumstances. And again, we thank you so much for presenting today, and we'll make sure to have the video available later for people online without the glitches. So our next talk is at 2:45. It's on perinatal mental health in Muslim women by Dr. Farah Islam and Dr. Rida Hashmi. Thank you so much.